Shock is also the electric shock, which uh, which is also there in anesthesia practice, because all the anesthesia equipments uh, they are related to some electricity, and the equipment with on which are using on being patient, that is also shock. So at the moment we are not discussing that shock. At the moment we are just trying to get a concept of what shock is. So anyone, what is shock?
Sir, in shock, there is circulatory failure leading to inadequate vital organ perfusion and
Okay.
decreased oxygen delivery.
Okay, like in the situation, because the basic purpose of whole of the circulation created by the lungs by receiving the oxygen and pumping of the heart by the and through the heart to the all body parts through the major vessels, the main purpose is to supply the oxygen. Okay, so the shock is will be that if body is unable to perfused, is it like that? Or it will also include if it is not being used, because there will be one type of shock. What is that type of shock in which everything is there but is not being used? Yes, Sumera, what is that shock? Or
Obstructive
anyone?
shock.
Not obstructive shock. What sort of shock occurs um, in which oxygen is not being used?
Septic shock.
Septic shock or anything else?
सर न्यूरोजेनिक शॉक.
Neurogenic shock, how?
सर न्यूरोजेनिक शॉक में तो सिर्फ एनाफ्लेक्सिस की वजह से ही जो है
No,
ना
no, no.
वो.
Try to speak in English.
Okay, sir. In neurogenic shock is because of the anaphylaxis or some
No,
type of
no, 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 not
hypersensitivity.
like that. No, Amna. Neurogenic shock is something else. Neurogenic shock occurs when during head injury there is severe sympathetic discharge. There is
Sympathetic
vasoconstriction.
overdrive due pain.
Yes, so
Yeah.
that is neurogenic shock is something else. Okay.
Mm-hmm. Yes, sir.
Or that is also this is, I think, histotoxic hypoxia which occurs in which oxygen is not being utilized. What about carbon monoxide poisoning?
Yes, sir. There is
Oxygen is there.
actually.
Oxygen is there, but
Yeah.
it is not being delivered. Okay. Or
Cyanide
as
poisoning.
cyanide poisoning, it's not being used. Septic shock is
Yes.
also like that, where it's not being used. Okay. So at the
Okay.
moment we will be considering the hypovolemic shock. Okay. There, and one of the type is obstructive shock, in which what is obstructive shock? Just we will touch few words about it. So Mara, what is obstructive shock? Which you used the word.
Sir, in obstructive shock occurs due to some kind of obstruction, like if
Mhm.
there is a tension pneumothorax,
Mhm.
any intrathoracic tumors, and
Mhm.
cardiac tamponade,
Mhm.
and in case of
Pericarditis.
constrictive pericarditis, air
Yes.
embolism and pulmonary embolism.
Okay. Okay. So, and there is another type which is called as redistributive shock. What is that one? As someone
So
was
that
telling,
is
anaphylaxis. This
septic
one,
shock, anaphylactic shock, and neurogenic shock.
no, redistributive, in which effective circulatory volume is not there. Like when there is anaphylaxis, there is a release of vasodilators, and blood is pulled from the intravascular compartment to the extravascular compartment. Am I right? Okay, so actually, this question is also for attention of the people who are appearing in EDA, because this question, this type of question they ask, they start from the they will be giving you a scenario, like they can give you a scenario that what will happen if a normal patient bled 2 liters of volume. Okay, so what will be the effect, how the body will respond, how the body will respond to acute hypovolemia. Okay, so who wants to answer? What will happen?
Sir, in acute hypovolemia, there will be sympathetic stimulation. Due to sympathetic stimulation, there will be tachycardia, and
Okay.
there will be
Sir,
Yes, please. Who wants to speak out? Please raise the hand. I will ask. Yes. Propofol wants to speak. Who wants to answer this question? Just raise the hand. Yes, please. Amna.
Sir, there would be compensation of that volume deterioration or depletion,
How?
and there would be compensation systematically, like system-wise. We can discuss it from heart and kidneys. What would do the heart and what would do the kidneys? Kidneys would they preserve and reabsorb the water. They conserve the water from
Remember one thing.
from
Amna. Everything which you will be saying will be correct. Okay. It is only the order which will be defining your answer. Okay. So do you think
yes,
that the kidneys function occur at the first? What is the first response? What is the first body part which responds to acute volume loss? What is the
that the
immediate which
body
occurs?
part
Tachycardia.
baroreceptors,
Blood vessels.
blood vessels and
Not blood vessels. Again,
baroreceptors.
baroreceptors. Okay. The immediate response to volume loss will be through the baroreceptors. Okay. So baroreceptors will respond what? In what? I would be very happy if the people, some of the, because I can see a number of people who are appearing in EDA, because actually this question should be answered by the people who are appearing in EDA IC. So I will be very happy if some of our friends take the lead, because this will be the question which will be asked to you, and this is an open-ended answer. Believe me, anything whatever she is telling is right, but it is only the order or correlation, or the in a nice way you are explaining to the examiner, that will make you successful. Okay, so first response will be baroreceptors. They will be doing what? They will be increasing the
So they will,
sympathetic discharge. Okay,
yes.
so where will be, what will be the effector site? What will be the effect?
So on the vessels.
Tachycardia.
What sort of vessels? You know, now your
So
answer is still not pinpoint. Okay, try to pinpoint the answer. Which
vasoconstriction
vessels?
occurs.
Vessels in the brain, vessels in the muscles, vessels in the intestine, vessels in the periphery. What? Which vessels?
Sir, the arteries.
I'm sorry.
Vasoconstriction.
Vasoconstriction predominantly where? That's what I'm trying to ask, because there will be some redistribution of blood from some parts, because what will be the aim? The aim will be that our bodyguards are active now, and bodyguard is sensing that there is acute volume loss, so they have to preserve some organs immediately. The vital organ supply they will try to maintain, and they will be redistributing the blood from certain areas to certain areas. What will be that?
Sir, here the vessels of the peripheral vessels and vessels of the muscles will be constricted, and the blood will be redistributed to our vital organs like heart, brain, and kidney.
Okay, so there will be tachycardia, and there will be vasoconstriction from the periphery, and from the like peripheral vasoconstriction. That's why you will be seeing a patient will call cool clammy skin. Am I right? That is actually a compensatory body's compensatory response to hypovolemia. Okay. What else? What else? Body's thirst mechanism will be active.
Yes, sir.
Okay. Mucous membranes will be dry. That's what occurring in shock. That will be the response to our compensatory mechanism. Yes, immediate response will be just give me a second, please. Yes, I'm sorry. Yes, please. Yes, continue, please. So what else will occur? Anything else? Yes, Amna. Yes, can you hear me? Yes, Sumera. That is will be the first response
Sir,
by the baroreceptor,
yes, sir.
and by
There
the
will be,
clinical, like peripheries, mucous membrane will become dry. There will be cool clammy skin. What will be, what else will be occurring? There is another thing you have to tell at this point of time.
sir,
Sir,
there
there
will be
would be
decreased
oliguria to conserve
tachypnea.
the water, body water.
One person please tell now. Amna, your turn is finished for a while. Yes, Sumera, please continue.
Sir, there will be decreased urine output and
Decrease urine output by,
tachypnea.
okay. The urine
Renal
output is
angiotensin system.
not the result actually. There is another important system we need, which will be activated here. The renin angiotensin aldosterone system. Okay. Renin angiotensin aldosterone system will be active, and it will be trying to conserve the salt and water, and that will be resulting in decreased urine output actually in this scenario. Okay, so you are telling the right thing, but
Yes, sir.
the mechanism, especially take this message for the people who are appearing in EDA. Okay, because they will be concentrating on this point, that what are the usual responses. Okay, what else?
So there will be tachypnea and there will be effect on the CNS system like confusion, restlessness, and coma. And there can be decreased CVP.
Okay. So actually, this is the body response to hypovolemia. Okay. So this is the body response to hypovolemia, and you can consider this thing in any acute shock, like any condition in which sudden volume loss occur. And now you can fit this knowledge when you are thinking about placenta previa bleeding, or gunshot wound, or anything like that. So mechanism is the same. Okay. So now if you just now what will be your response as an anesthetist when you are dealing with such patient and this scenario? If you know that there is a volume loss going on there, because there will be two situations in which whether there is internal bleeding or external bleeding. Okay, so if it is external bleeding, you will be doing the approach of actually, because we are not discussing trauma at the moment, but actually your approach will be towards a damage control resuscitation. Okay. Anyone knows about damage control resuscitation? What is damage control resuscitation?
So damage control resuscitation is done to avoid the lethal triad of hypovolemia, shock, sorry, hypothermia, shock, and the third thing I forgot.
Coagulopathy. Yes.
Coagulopathy. And because there are some components of damage control resuscitation in the form of something which his surgeon is doing, like he's controlling to he's trying to control
Yes.
the
Life
breathing
and
by
limb saving.
just packing. Okay. And the next step will be the definitive management. And the basic theme of damage control resuscitation is that you are not trying to absolutely correct the parameters. You are just making certain realistic goals, and then you are just trying to exhibit. Okay. So just a second, please. If we just try to classify in shock into different in the same scenario, there is one stage of compensation, and then patient may be decompensated. Okay. When these responses will be exhausted, we will say that patient is in decompensated state. So usually, because this scenario will be there in either they can in the form of any external bleeding, as I told you, ruptured abdominal aortic aneurysm, any intra-abdominal bleed, or anything like that. So your approach will be, what will be your approach? Airway, breathing, circulation, taking large bore IV cannulas. Okay. And resuscitation. Does CVP come in resuscitation or no?
No.
Okay, because CVP, because usually you are looking for 14 gauge. So usually even vascular sheaths you can try. So the CVP
Yes.
is Swan-Ganz, not really. In resuscitation, Swan-Ganz will come in in a patient in which you have to give judicious fluid. Okay. So in that patient, and then, or if, for example, if any after the initial resuscitation, that now this patient is requiring vasopressors, then you will be preferring to take a central line. Okay. Otherwise, the message is that CVP will not come in the initial resuscitation. Okay. What else? Anything else at that time we can do? We will be activating. There is a terminology called as massive transfusion
protocol.
Okay. Massive transfusion protocol. And if massive can anyone explain what is massive transfusion protocol?
Yes, sir. In which in massive transfusion protocol, we basically ask the pathologist to give us blood products for RCCs, platelets, and cryoprecipitates. O negative.
Actually,
Basically,
it's
we
actually
demand O negative
massive.
blood.
I will just add to it that it is it's a hospital-based protocol in which they decide usually O positive or O negative blood group, uncross match with a certain specific number of blood and blood products. And when they will only call activate massive transfusion protocol. Okay. So when they activate massive transfusion protocol, they will just, it's called as shock pack. Okay. So it is also called as shock pack. So when this is transfusion protocol in the hospitals where it is set up, so immediately that number of blood and blood products, it will be including PRBCs, FFPs, cryoprecipitates. Okay. And the number may be customized. Okay. So
Yes,
it
sir,
may
like
be O
in
positive.
military, we ask for 1:1:1 in military resuscitation. In war,
Yes.
war.
Yes, because in some part of world, we still use the word of blood transfusion, but actually it's changed by blood and blood products transfusion, because there is no concept of blood transfusion now, where we are giving the component therapy. Okay, so this will be one of the factor will be the initial airway breathing circulation management and activation of massive transfusion protocol, resuscitation via large bore IV cannulas. What else you need to tell if you want to tell this thing, in addition to the immediate control in which the C will come? Okay, what else? There are certain things which you can tell, and at this point, rapid infuser system, level 1 infuser. Okay, level 1 infuser may be needed to give these products quickly, okay, and fluids quickly, and then warming devices. Okay, blood warming devices, because if you are giving the fluid, or sorry, this blood or these fluid management, you are actually giving the fuel to lethal triad.
Yes, sir. Coagulopathy. Yes, you can.
A lethal triad,
The
because it will be
hypothermia can
causing
goes to
hypothermia. Okay, so at the same time, you are anticipating the complications of massive blood transfusion, and you are trying to cope with it, like you are doing serial ABGs. You are, if you have HemoQ, it will guide you the acute changes, and you can direct your fluid management. There is one more bedside investigate. Usman, you know it, so I think let someone else. If they don't answer, then you will answer. What is another gadget which you will be using in addition to ABGs, HemoQ? There is another thing which should be there. What is that? To direct the fluid
Sir,
and
thromboelastography.
thromboelastography or rotum.
Capillary refill time.
I'm sorry, Sajjad, please speak again. I mistakenly mute you. Sajjad Ahmed.
Capillary refilling time.
I'm sorry.
Sir,
Capillary
capillary refill,
refill.
but it is not a bedside test. It is a examination. You can
Actually,
see
he
the
is
capillary refill.
absolutely right. We missed to discuss this point when we were talking about the signs and symptoms. But actually, it is not the test. You are to guide the fluid therapy. Actually,
Yeah.
it will be there for the assessment. One more thing,
Primary
which,
survey.
in the primary survey, there is one more thing, which
Focus
is
assessment of fast focus assessment of
yes,
ultrasonography.
yes. The fast scan is also there to rule out the cause. And another thing, in addition to thromboelastography, because this will tell you what exact blood products you need. Okay, and to cope up the complications related to blood transfusion, what you will be doing ABGs, and you are looking at the ionized calcium. Okay, because in the stored blood there is more concentration of potassium, which can pose the patient for arrhythmias. Okay, so you have to and there is in the there are chances of decrease calcium, ionized calcium levels. So you have to monitor ionized calcium level, and it is better to anticipate and give. You ideally it should be checked with the ABGs and replace accordingly. You can give calcium gluconate or calcium chloride. What is difference between if you want to give calcium gluconate or calcium chloride? What will be the difference?
The difference is in ionized calcium amount.
Ionized calcium is more in
Calcium chloride.
there is 3 times
Calcium
more
chloride
ionized
is
calcium
more
in
concentrated.
calcium chloride. Okay,
Yes.
so what else?
Calcium
Anything?
gluconate is 792.
I cannot hear you, please. Can you be a little loud?
Calcium gluconate contains 92 milliequivalents of calcium, and calcium chloride contains
270 something.
277 milliequivalent.
Yes.
Yes.
Okay, so
That
it
is
is more
different.
potent, but you have to give it
Calcium gluconate will be 10 ml, and calcium chloride give 3 cc in month. is equal to that 10 ml of calcium gluconate.
Yes, like 3 times, and there is some guidelines to give calcium. You can give it through peripheral line, or you should
The
give it through
calcium
central line.
gluconate can be given through peripheral line, and calcium chloride can be given from central line. Should be given.
Okay, but actually it should be given a little slow. Okay.
So
Okay, so some words between how to we have discussed a number of aspects, because I told you this topic is very difficult to explain actually, because it's an open-ended question. Believe me, so many topics of discussion come into this topic of shock. I'm just trying to give you a concept rather than only the bookish things, so that you are able to approach the patient in a better way. And if they are asking you in the exam, because if you just recap in the exam, they can ask you to start from what is shock, then they can ask you what are different types of shock, and whatever their question is, they can, because it will be not possible to discuss in one session. We will have some more session to complete all the types of shock. So I just focus on this this time on the hypovolemic or one of the will be hemorrhagic shock. We are focusing at the moment on hemorrhagic shock, but actually redistributive shock is also hypovolemic shock, because effective circulatory volume is decreased. So in real sense, it's a little bit complicated approach. And if you have a patient, a young patient with acute management, there are something else. But if you have a comorbid patient now presented with the acute hypovolemia, your approach will be a little different. Okay, because in that scenario, you have to direct your management according to the need of the patient. Okay, like you have to add some inotrope as well, because otherwise in normal patient with acute hypovolemia, you hardly need to have inotrope. But in other way, in cardiogenic, if it is combined cardiogenic shock on top of this hypovolemic shock, then you have to be a very judicious in giving fluids. You have to be using inotrope and vasopressors and fluids, and you have to use other parameters which we discussed before as well a number of times, in the form of this focused echo. Okay, and your approach is multidisciplinary team.
Video.
There is no video at the moment. I will be showing you some, just a second, because I just want to give you a concept, and then some of the points which we have already discussed, I will show you here, which we have a number of things we have already discussed. If we just, because this is also important, okay, this assessment of hemorrhagic shock, class 1, class 2, class 3, class 4. Usually in class 3 and class 4, you need to transfuse the blood. Okay, and you have to just, and actually this loss is also dependent on the initial hemoglobin. Okay, what was the baseline at which this disaster started. So that will also be dependent on allowable blood loss or allowable for that patient, and you will be responding accordingly. So you will be assessing according to the parameters like pulse rate, blood pressure, and then the mental status parameters. And usually if it is class 3 and class 4, so usually they definitely need blood transfusion. Maybe in a normal patient, class 1 and class 2 will be compensated. Okay, so whose camera is on? Can you just switch off your camera, please? Fahad, Dr. Fahad Mohammed Karakat, can you close your camera, please? Okay, so this is, we discussed hemorrhage, decreased blood volume, and there is decreased cardiac output, and this is the response, compensatory mechanism, vasoconstriction, cellular anoxia. This is how the vicious cycle of occurred. So few words about colloid versus crystalloid. That's what I was about to discuss. What would you prefer? colloids or crystalloids? Yes.
Crystalloids.
I'm sorry.
Sir, after initial resuscitation, crystalline fluid will be given, but crystallite and colloid, both fluids has its own advantage and disadvantage.
Yes. It will be colloids can bridge initial period, and it depends on which colloid you have. Okay, like if you have plasma proteins, it is relatively safe as compared to if you have dextrans, for example, or hysteril or gelafendin. Okay, so because if you are giving more, there are problems related to platelet dysfunction, there are problems related to allergic reactions, there are problems related to uh, what else. And actually in this scenario, when you have class 3 or class 4 shock, the oxygen carrying capacity will not be maintained. Okay, so you need colloid. What will be the advantage is that it will give the acute volume replacement better. Okay, so you can give initially colloid as well, or co-crystalloid as well, but later on you have to give blood. So actually there is no much difference in a condition in which the patient is requiring blood ultimately. So even if you give crystallite too much, it will do because the response will be 3 times more to colloid. Like if you are giving 1 ml of colloid, you need to give 3 ml of crystallite. So if you are giving 1 liter of colloid, you are giving 3 liters of crystallite. So there the dilutional problems will start. Okay, so there are more chances of dilutional coagulopathy and dilutional problems with if you are giving only crystallite. Okay, so there is no single consensus on whether you should use colloid or crystallite. You should be using your own strategy according to the situation, according to the availability of the resources, and according to availability of the colloid which you have. Okay, agreed? Or any other point? Okay, so this is, I forgot to mention lactate. Okay, so whenever you are your end, you can follow your resuscitation in the form of lactate. But if there is one condition in which there is gangrene, okay, if there is for example, there is ischemic gut, and you are giving the resuscitation, still maybe lactate level will not go down till the time. Can you hear me?
Yes.
So maybe in that scenario you have to, like, because actually the approach is of ACLS, primary survey, secondary survey, resuscitation, management, evaluation, having the approach which we use in ATLS, sorry, not ACLS, ATLS. Okay, ATLS approach. So you can have a look here on some of the things which we have already discussed. Okay, so shock is defined as sacrality failure in leading to inadequate vital organ perfusion, oxygen delivery, and nutrients to tissue. Okay, so in that there is one stage of compensation and then one stage of decompensation. And hypovolemic shock may be hemorrhagic or non-hemorrhagic, that spacing, as I told you, which occurs in any conditions like that. Okay, and hemorrhagic, we will go in details of cardiogenic shock and obstructive shock as we discuss, in which not able to pump, either in the form of tension pneumothorax or cardiac tamponade, or systolic failure which occurs in the embolism or acute aortic stenosis or things like that. Okay, so this we have discussed. We discussed that there is a tachycardia, adrenaline stimulation, low pulse volume. Okay, and cardiac output will be decreased. Okay, clinical features we have discussed: thready pulse, tachycardia, tachypnea, hypotension, oliguria, confusion. Now you see, when we understand, it is very easy to evaluate ourselves. So this is how we should be thinking, that there will be some symptoms, there will be some signs, there will be something which you will be getting the points, that if you see a patient in this scenario, you are anticipating that patient is going down. Okay. And okay, so what is that? Assessment of systemic perfusion, vital signs, urine output, acid base, lactate clearance. That's what I was telling you. And then further will be according to the scenario. We will go in details in the other types of shock. This one, cardiac output monitoring or mixed venous oxygen saturation, and other things. Okay. So any question up till now? Okay, so we will stop here, and we will continue our discussion on other type of shock, maybe cardiogenic tomorrow, inshallah. Okay. Thank you.